Good afternoon, everyone, and thank you, Dr. Vikas, for having me here in this session on retinoblastoma. So I will be taking you through the very basic aspect of retinoblastoma, and especially, targeting the postgraduate students on update in the diagnosis and classification. I'm Dr. FAIROOZ, ocular oncologist and a retinoblastoma specialist. I'm grateful to my team of retinoblastoma, including the pediatric oncologist, radiation oncologist, everyone who has been working with us on retinoblastoma. So one important thing that I want to emphasize here today is retinoblastoma is a clinical diagnosis. And that is exactly why we need to know the classification, because depending upon the features, the clinical features, that is how we classify it into different groups, into the tumor, nodal, metastasis, etc., etc. There are a few things that we require for this, and in our clinical practice, it's just not a clinical evaluation, seeing the patient in the clinics. We do take these patients under general anesthesia and do a very detailed evaluation, and in fact, the documentation is so very important, because depending upon each and every minute feature of the tumor, that's how we classify these lesions. And why? Because depending upon the classification and the staging, that is how we actually decide our management protocol. All right. And well, there are investigative modalities, which is in fact additional. So again, retinoblastoma is a clinical diagnosis. So this is basically the clinical classification of retinoblastoma depending upon the features. So we have exophytic, very basic, I'm sure all of you know about it. Endophytic. Endophytic is where the tumor has grown into the vitreous, so it kind of spits out vitreous seeds. It could be focal, it could be diffuse, and this is how the endophytic tumor looks like. The mixed, it can have both exophytic and endophytic component, and a diffuse infiltrating, where the tumor is diffusely involving the retina. You actually see like a very very thin retinal thickening and discoloration of the retina, which is of course white in color with specks of calcification, as you can see here. Now this is quite a recent clinical classification of retinoblastoma, where this is a patient who did not have absolutely, the retina up to the pars plana was absolutely normal. Retinoblastoma arises from the retina, but this was an anterior segment presentation of a retinoblastoma. In fact, initially the child presented with a uveitis picture, and gradually the child started growing this small lesion in the corner of the angle, did an FNAC, and it was confirmed to be a case of an diffuse anterior segment retinoblastoma. You should keep this in mind, especially in older children. They can present with this kind of a scenario. Now, we have been recently doing a lot of work on vitreous seeds in retinoblastoma, which is something has been very difficult to treat, and currently we have this intravitreal chemotherapy that we have been extensively using in controlling these vitreous seeds, and then subsequently we also started classifying the vitreous seeds in order to assess the outcome and prognosis of vitreous seeds. So this is how we basically classify into spherules, like as it clinically appears. It can have dusting, it can be like having a dusting in the vitreous, and also clouds. So this is the very basic classification of the vitreous stage. Now, grouping and staging in retinoblastoma. So grouping is basically for prognosis of vision and eye salvage, and staging is basically for prognosis for life. All right, so current classification system that we use is International Classification of Retinoblastoma. I'm sure all of you know about it, A to E. It's very easy, universally used, which was put forward in 2003, and the American Joint Commission of Cancer, AJCC TNMH classification, TNMH, mind it. So retinoblastoma is the only malignancy in the body which has given an H to the TNM. Usually we have heard about TNM, but retinoblastoma being a genetic disorder, it also has an H. So students, remember, whenever you talk to your examiner, when they talk about TNM classification, add an H in retinoblastoma. All right, yeah. So I'm just going to make it slightly easier for you, kind of taking you through the grouping and the TNM together, so that it's easy to remember, although you'll have to go and revise it again. So we have group A, which is like small, A for small, less than 3 millimeters in basal dimensions, and away from the fovea and the optic nerve. That is group A. Group B stands for big, and B also stands for bubble. So it will be more than 3 millimeters in size, and it will have bubble, in the sense it will start having exudative retinal detachment around. Okay, so there will be subretinal fluid around the tumor. So that stands for B. Now correlating this to the clinical TNMH classification. So we have in TNM T1, where we have tumor less than 3 millimeters in size, and 1B, which is more than 3 millimeters in size. So T1, there is one component which is taken care of, that is size, and this correlates to group A and group B. Okay, T1, which is actually group A and group B, kind of correlating to it. Now C and D is a stage where we start having seeds. It could be subretinal seeds, it could be vitreous seeds. Now C stands for confined, where there is a focal seed. D stands for diffuse, where there is diffuse seeds. Okay, so this is C, group C with confined seeds, and group D with diffuse seeds. All right, now let me switch over to the CTNM again. So in CT2, they have fluid and seeds. All right, A is with subretinal fluid, B is with vitreous and subretinal seeding. So in T2, there are two components which is being taken care, fluid and seeds, which is again correlating to C and D. Okay, done? Perfect. Don't forget it. All right. Yeah. Now we have group E. E is an advanced intraocular retinoblastoma, where we have all the clinical risk factors which can have a possibility of a systemic micrometastasis, including neovascular glaucoma, massive intraocular hemorrhage, aseptic orbital cellulitis, and that is due to necrosis of a large tumor, which actually presents like an inflammation. And after a very bad inflammation, in fact, these eyes can go for phthisis also. You know, the entire structure is altered, and then you can even have a phthisis bulbi in retinoblastoma, and that is group E. All right, yeah. Now, group E is very extensive, and that correlates to T3. Okay, T3 is advanced intraocular tumor, and depending upon the severity, phthisis, pre-phthisis, tumor invasion of the anterior segment, raised IOP with ophthalmos and neovascularization, high FEMA, massive vitreous hemorrhage, aseptic orbital cellulitis. In T3, there is A, B, C, D, E. All right, easy to remember. Perfect. All right. So that is how group E correlates to. Now T4 is something where it has gone outside the intraocular confines. It has gone out of the eyeball. That is T4. Now depending upon the involvement and the extent, again there is T4A and T4B. When newer classifications comes into vogue, we always dissect it as clinical practitioners. So there is a little bit of issue with this classification over here. Okay. Now I'm going to tell you that. So there is a radiological evidence of retrobulbar optic nerve involvement or thickening of the optic nerve involvement or the orbital tissue. Optic nerve involvement in retinoblastoma is the most dangerous. You know that. Optic nerve is connected to optic chiasm, brain, and there is a high risk of central nervous system involvement if the optic nerve is involved. But if it is only related to the orbit, it's an extraocular extension but not involving the optic nerve, no CSF being involved, it actually has a slightly better prognosis than an optic nerve involvement. So some of us believe that T4B should be actually slightly better than the T4A, right? Yeah. So, well, we have mentioned this to the organization who have come across with AJCC. Obviously, every classification, every system, there is an evolution and change. So, probably this comes out in the next edition. Yeah. So, this is something like very glaringly not acceptable. All right. But this is how it is at this point of time. So yes, R is for regional lymph nodes, metastasis. Now metastasis, again, we have M1 and M1A and M1B. Tumor involving distant sites like bone marrow is slightly better prognosis than that with the CNS involvement, as I told you. All right, yeah. Now hereditary, I already told you. TNMH classification, even there is a pathological TNM classification in retinoblastoma. When you take out an eyeball, enucleation is not an end of a retinoblastoma treatment. It goes to the pathologist, all the high-risk features are looked into, and even they have a TNM classification. That is pathological TNM classification. As a treating specialist, what I need to know is whether there is a high-risk feature or not. All right, yeah. So in T1A, it's without any local invasion. In fact, there is no local invasion. So the possibility of high high-risk features is very, very less in PT1, whereas in PT2, there is focal choroidal invasion and prelaminar or intralaminar involvement. That is high-risk feature. So T1, no high-risk feature. PT2, yes, high-risk feature. PT3, lots of high-risk features: massive choroidal invasion, retrolaminar invasion of the optic nerve, scleral involvement, full thickness involvement of the sclera. And these are dot on high-risk features pathologically for retinoblastoma. And well, PT4, as clinically you know, pathologically also, if there is evidence of extraocular extension, it is PT4. Now, orbital retinoblastoma, in our part of the world, we see this extraocular extension. So this is actually put forward by Dr. Santosh Honavar, and we do practice this in our clinical evaluation of orbital retinoblastoma as primary, where they initially present with extraocular extension; secondary, where they have undergone enucleation, but then there is an orbital recurrence of the tumor; accidental, where some surgery like retinal detachment surgery, vitrectomy has been done in these cases, and there is an extraocular extension; overt, where radiologically you have missed it, but there is a surprise on table when you do an enucleation, there is a slight extraocular extension; and microscopic. Now, international staging system, as I told you, for live salvage, stage 1, where it's entirely removed; stage 2 with microscopic residual; 3 with orbit extension; and 4 is metastatic disease. So applying staging and grouping in retinoblastoma is very, 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 very important, not only for documentation and also for taking decision for management in retinoblastoma. I say appropriate decision. All right. So this is exactly how we do it. We identify the disease, laterality we identify, we apply the group, we apply the stage, and then the treatment status in all these patients. So well, a thorough detailed history is so important, clinical examination is so important, and definitely classification and staging in retinoblastoma is very, very important. Thank you so much.
Thank you, Dr. FAIROOZ. That was excellent, especially putting the TNM staging and the ICRB grouping together into proper